Thank you, Bernard. I will try to make that lecture because my voice is gone, so I hope it's going to make the job. So I've been asked to talk about the aortic valve. Contrary to the mitral valve, I think there is less of a place for 3D echo right now for assessing the aortic valve, but there's increasing interest in doing that, and I will show you some examples. So the aortic valve is a complex valve, as the mitral valve is quite different, but nonetheless is a very complex valvular apparatus. We used to see the aortic valve as only the aortic cusp, but like the mitral valve, there's an extra cusp apparatus, which is essentially made of the aortic root, which can be seen as the native stent of the aortic valve. And if any of these items, either the cusp or the stent, are not perfectly aligned and functioning, this will lead to aortic regurgitation. This is just to show you the complexity, and the aortic valve has a semilunar implantation into the aortic root, and you see here very beautifully on this stentless valve the fibrotic reinforcement at the base of the leaflet's insertion into the aortic root and the interleaflet triangles. Now with 3D echo, we can have a very nice view, of course, of the aortic valve, as we can have from the mitral valve, but we have to realize there are some hints and tips and tricks for the aortic valve. First of all, it's a much thinner structure than the mitral valve, and the mitral valve is something like 3 to 4 millimeters in thickness in some places, which is relatively easy to image. And in addition, the ultrasound beam is hitting the mitral valve in a perpendicular fashion, so it gives you a very good contrast between the cavity and the valve itself. The aortic valve is much thinner. It can be something like 200 microns in some patients, so it's very thin. And because of that, there can be a lot of dropout artifacts, and particularly since that valve is not very well oriented compared to the ultrasound beam, since it's relatively parallel either from the transthoracic or the transesophageal point of view. So because of that, you can have a lot of dropout artifacts, and sometimes you have the feeling that you can have in some places, perforation, I would say, but this is, of course, not usually the case. So you can also have a very nice view of the aortic root, and this is essential if you want to make the assessment of that valve complex. And the aortic root is essentially delineated not only by what we call the aortic annulus, which is a virtual annulus and does not really exist, but also delineated by a very important structure, which is the sinotubular junction, the size of which will determine the level of tethering and of coaptation of the aortic leaflets. And this is very important in case of aortic regurgitation, as I will illustrate it. So I will talk essentially about two different topics, aortic stenosis, and I will cover that very rapidly, and second, aortic regurgitation, in which I think there's a real place for 3D echocardiography. So let's first start with aortic stenosis. The role of 3D echo in assessing aortic stenosis is essentially a help in the quantification of the disease when you are dealing with difficult cases, like you have problems in assessing the subvalvular flow, you don't see the valve very well, and you cannot assess the valve area correctly by transthoracic echo using the continuity equation. So 3D can help by many ways. First of all, it can help you in making an appropriate planimetry of the orifice. Second, if you have problems in measuring stroke volume using the subvalvular flow, then you can use the 3D stroke volume from the 3D echo. And for those who are involved in TAVI procedures, it is also a nice way to look at the aortic annulus dimensions. Let's first start with the planimetry. You can use the biplane capabilities of 3D echo to make a more appropriate planimetry than you could use by simply steering across the valve in 2D mode in short axis, and here you can decide really to make your measurements at the tip of the valve, see the opening into and then making the planimetry. And it has been shown that if you do so, the comparison between the biplane T, the TT and the TE is quite good and allows you to do this evaluation by three-dimensional transthoracic echo. One of the important issue here when you do the 2D planimetry, which we often do either transthoracic or transesophageal, is that the aortic valve is not flat when it opens. It has a conical shape, and then if you make your cross-section a little bit into that conical shape, you're going to markedly overestimate the degree of opening. This is very well illustrated with this progressive cross-section across the aortic valve with 3D, and you can see that when you are very high in the valve at the level of the opening, it's much smaller than when you have the feeling that you see the opening at a much basal portion of the valve. So it's very important to use 3D when you do this type of planimetry by 2D based on 3D images. And this can be easily understood because there is a significant movement of the aortic annulus during systole. So usually your eye is attracted by what happens in diastole, and you place your cursor in the diastolic position, and this is usually not good when you make the assessment for the systolic opening. You can also use the 3D capabilities of measuring left ventricular volumes, which are very accurate to measure 3D stroke volumes. This is to show you that the measurements of left ventricular volumes by 3D, both in systole and diastole, are very accurate, a study that we made some years ago with the QLab system. And of course, if you combine that stroke volume with the peak velocity measured by CW Doppler, you can make an evaluation of the valve area by continuity equation. And this has been shown to be a very accurate way of measuring the aortic valve area as well. If you are unable to measure the subvalvular flow, for instance, if you have subvalvular obstruction, if you have a hypertrophied septum. Now, for those performing TAVI procedures, it's also important to have appropriate measurements of the annular dimensions. We usually do that by 2D and taking only the anterior-posterior dimensions, but you know that from CT imaging, these dimensions are not probably exactly appropriate, since we know that the orifice of the aortic valve, and particularly at the level of the annulus, is far from being circular. It's very often elliptical, and if you're only taking the anterior posterior dimensions, you clearly underestimated the size of the annulus, and you can undersize your prosthesis and then lead to some degree of paravalvular leak. So it's very important to have a good evaluation of this. Many people do that by CT, but it can be done by 3D TE as well. And the correlation between the CT and the TE measurements are quite good, and at least the difference between the two is markedly reduced when you do the 3D, you use the 3D TE compared to only the 2D dimensions. So I would strongly recommend that if you don't have a CT, then you use 3D TE to make your annular dimensions calculations in order to appropriately size the prosthesis that you're going to implant in the patients. So let's turn to aortic regurgitation, because I think that 3D TE can help us in assessing valve repairability, and this is something which is a very rapidly evolving field. And although in many places, in many hospitals, probably you never repair an aortic valve or very seldom do so, in our institution, more than 85% of aortic valve regurgitations are repaired, so we are very close to the rate that we can obtain with mitral valve repair. There's a lot of tips and tricks from the surgical part, but clearly assessment of the anatomy and the function of the valve is critical in that. You can do that, of course, with two-dimensional echo, and we have demonstrated we can do so. What I will try to do is that, to show you today, is that we can do it with 3D echo as well. So we used a very similar classification of aortic valve dysfunctions as the Carpentier classification for the mitral valve. We just flipped it upside down, and we identified 3 different types of aortic valve dysfunction in aortic regurgitation. The type 1s, which are essentially due to root dilatation and corresponds to a normal leaflet motion when you are in the operating room. There are a lot of cusp prolapses. Before we embarked into that program, I really ignored that there were so many cusp prolapses around, but this is very frequent. Up to 20% of all aortic regurgitations are due to aortic cusp prolapses, and they are very easy to repair. And then there are the type 3s, which are not repairable, which are the restrictive leaflet motion. I will show you some examples, but in which for echo, we also classified all the destruction of the tissue, because at the level of the aortic valve, it is critical to have a significant amount of tissue to work with so that you can perform the repair. As long as you're missing tissue, you have to close the gap with pericardial patches, and usually this is not associated with very good long-term results. So as for the mitral, we have the surgical and the cardiologist point of view. We both make the valve analysis, and we have to speak the same language. So we have 3 types of dysfunction. Type 1, with the normal cusp motion, which is usually due to the aortic root dilatation. The type 2, which is increased cusp motion of cusp prolapses, and then the poor quality tissue or quantity of tissue as we classified as type 3. So I will just illustrate this by a couple of examples to show you the capabilities of 3D echo in doing so. This is a root and valsalva aneurysm that can be pretty much well assessed with 2D echo, of course, but here we have the 3D view of it. And I think that when you use that, the simple en face view of 3D rendering is not sufficient. You really need to go into the capabilities of the 3D softwares to make 2D reconstructions so that you can make all the measurements you need in all the directions that are possible, and this is possible with 3D echo. This is just an example of how you can do it. Then you, of course, cut across the different structures, and then you can make your measurements at the level of the annulus, at the level of the sinuses of valsalva. You can measure the size of the sinotubular junction. Of course, with the current 3D sectors, we sometimes have problems with assessing the root when it's over at the level of the ascending aorta, but you just have to move your probe so that you can assess in every direction of space the dimensions of the aortic root as well. This is another example of a patient that had asymmetrical sinus dilatation with essentially the right coronary sinus, which is a very bizarre shape. You can use, as I said, the different cropping capabilities. This is with QLab to just show you how much these images are alike and even of better quality than the 2D images. You probably better see the origin of that right coronary artery here than you can see it on the 2D images. And you can, of course, use the capabilities of the cropping not only to look at the anterior or posterior dimensions of the root, but also to make cross-section in other directions, here perpendicular, which is usually very difficult to do that with a 2D. You need to go to these gastric views, and most of the time they are not a very good quality. So here you can have every information you need for your measurements of the different sizes of the sinuses in 3D. Very important part of the diagnosis, and I would really engage you to look at the valve when you are dealing with aortic regurgitation, is to identify cusp prolapses. This is an example of a partial right coronary cusp prolapse. So let's just orient ourselves. This is the left, this is the non-coronary cusp, the right is in front. And as you can see, the distal part of that right coronary cusp is going down into the LVOT. There is a small gap there, and if we change the orientation, we would see the orifice of the jet. And this is usually associated with a bending here in the middle of the valve, and the distal part is just everted into the left ventricular outflow tract. You can use the different capabilities of 3D softwares to see whether this prolapsing segment of the right coronary cusp is involved in both its relation to the non or to the left coronary cusp. And here is a cross-section across between the non and the right, and you see that the right is prolapsing with the bending in the middle of the right coronary cusp. And then you do the same between the left and the right, and you see this bending clearly here. So it's a distal cusp prolapse that involves every line of coaptation between the right coronary cusp and the two other cusps. It's easy for the right coronary cusp. You can do it with 2D. It's very complicated to see coronary cusp prolapses from the posterior cusp with 2D echocardiography because you're not perpendicular to the coaptation. Here is an example of the left coronary cusp prolapse. You see the bending here, and you have, it might not be that easy when you see the en face views, but you will clearly see that when you crop across the valve, it's much easier to make that diagnosis, and that diagnosis is pretty much difficult with 2D echo. Of course, 3D color can help. You see that there is regurgitation in between the left coronary cusp and the two other cusps, and there's a relatively long area of lack of coaptation. This is when you do that in 2D. And the interest here is really to use the cropping capability. So the left is there, the right is here. So if there is any prolapse there, you should see the bending and the distal cusp prolapse on the cut that goes through that coaptation, which is shown here. So the right coronary cusp is on the bottom, and you see exactly what we've seen on the previous patient with the bending of the left coronary cusp and the distal cusp prolapse. And as you can see here, if you make the cross-section between the left and the none, there is almost no prolapses at that level, probably a very little bit of it, but most of the prolapses occurs between the right and the left. So it allows you to make the appropriate diagnosis, which is often very difficult for posterior cusp prolapses. Of course, many of the prolapses involving the aortic valve are due to bicuspid valves. This is an example of a type 1 bicuspid valve with 3 sinuses and a raphe, and you see that the valve containing the raphe is prolapsing with a lack of coaptation that you can see between these non-conjoined and the conjoined cusps, which is here from a little bit far away here and probably with a much better view. I was talking to you about the dropout artifacts, which are very clear here in that mode. I would probably suggest that you use the live 3D views, because the live 3D views are usually less affected by these dropout artifacts compared to the Zoom 3D volumes. This is an example again of this type 1 bicuspid valve, when you can see by cropping across the valve that the conjoined cusp, which is shown here, is going below the opposite cusp and provides a prolapse. And just to show you the comparison between 2D and 3D, for years we've been used to only use 2D echo images, but you see they're really much alike, and you can have exactly the same information by using 3D, and in some cases you get much more information than with 2D echo. This is an example of a type 0 bicuspid valve, so there are only 2 sinuses and 2 large cusps. Usually they are facing each other with a 180-degree orientation. And in this case, it's a bit more difficult to see which segment is prolapsing. Let me go back to this. Here we go. It's obviously the largest of the 2 cusps that is going down, but in the en face view, it's not that easy because we are only a couple of millimeters, and this rendering is rather difficult. So you have to go into the cropping capabilities, and there, again, you are able to make a perpendicular cross-section, which you are unable to do with 2D echocardiography, and you see that the anterior cusp is prolapsing below the posterior cusp. Also very interesting is to look at the type 3 dysfunctions. This is an example of, again, of a bicuspid valve with extensive calcification at the level of the raphe and a lot of restriction in the valve. And I will show you the difference between 2D and 3D. Honestly, when I look at the 2D images here, of course there is a little bit of calcification of the raphe, but you know, a little bit of shaving and the surgeon could be able to get rid of it. But when you look at the 3D echo, obviously the extent of disease of the valve tissue is much larger than with 2D echo, and probably this valve is not repairable. And if you have to do so, you will probably have to take away all that chunk of calcium there and replace that by pericardial patches, and this will probably be a non-long-lasting result. Another type of restrictive valve is the type 2 bicuspid valve, which is the unicuspid valve with 2 raphes, one that you can very nicely see here on the left side and the other one on the right side. very surprisingly, these are very easy to repair valves. Of course, you have to almost take away all the diseased part and replace that by two pericardial patches that will reconstruct the commissure. But these are the ones that are probably long-lasting because there is a lot of experience in the pediatric world with curing these valves without replacing them with very good long-term results, at least 10 to 20 years follow-up. Another very easy diagnosis by 3D is the quadricuspid valve, an example of which you see here, which is usually a quite restrictive valve, as you can see from these 2D reconstructions. As you can see, there's a lot of restriction in the movement of these leaflets, and although you have 4 leaflets, they do not co-op very well, not by prolapse, but essentially by restriction, and it is very important to make that assessment. And finally, the destroyed valve by cusp perforation due to endocarditis, but you don't really need to have 3D echo to make that assessment. So we have previously shown that there was a good correlation between what we find with echocardiography and the repair rate by the surgeons. Here are the repair rates obtained in type 1, so essentially in the root dilatation and prolapses type 2 in yellow, with an excellent repair rate. More than 90% of the valves can be repaired with very little events in the future. About half of the type 3s can be repaired with a lot of recurrence in the follow-up, so probably some of them are repairable, but most of them shouldn't be at least attempted, and aortic valve replacement is probably better in these patients. And this is the long-term results in the type 1, type 2, and type 3 echocardiographic valve dysfunction by echocardiography. So in conclusion, 3D echo is clearly a versatile technique that allows for precise delineation of the aortic valve anatomy and function. In patients with aortic stenosis, 3D echo can be a useful adjunct for 2D echo for the assessment of aortic valve area. You can do it either by direct planimetry of the orifice or by use of the continuity equation when you use a stroke volume by evaluation of left ventricle volumes. In patients with aortic valve regurgitation, 3D echo can be used with equal accuracy to 2D echo to assess the mechanism of valve dysfunction and for the potential of valve repair. And as I illustrated in patients with posterior cuspous prolapses, 3D echo is probably superior to 2D echo in delineating the extent of excess cuspous movement. I thank you for your attention.